G'day guys, my name's Nick Amidy. I'm a 5T at Amidy, and today I will be doing a short presentation on a pulmonary edema patient that we backed up a P1 crew for that later turned out to be Takotsubo's cardiomyopathy, so it became quite an interesting case. It was just another day in Nowra. We'd been on day shift and were contacted by Southern Control requesting an R1 IC backup for a query APO patient. We had a crew coming from Old Errol Bay, which is about half an hour south of the hospital where we were. The crew sounded stressed during the radio call, so we didn't even finish making the bed. This patient was going downhill pretty rapidly, and luckily we just actually finished an APO job prior where the patient had responded quite well to CPAP, nitrates and furosemide. And prior to these two, it had been 12 months since my last APO, so it was quite interesting. The initial crew's struggles on scene, their access was difficult. They had no backup for an assist load. We had no crews in the area due to not only being 3 crews down in the area, but basically all of our crews were stuck at hospital as well. That's been pretty bad in our area recently. They found the patient naked, slumped on the toilet, very fatigued, with gradually worsening agitation and refusing flatly to go to hospital. Once they finally convinced her to get into the car, they had quite a long run. There was a lot of roadworks going on the quickest routes due to the weather patterns around here trashing the roads. So they had a fairly long run up to hospital. What did they initially find? We've got a 54-year-old female, a history of obesity and heavy smoking and heart troubles, which she didn't really expand on in the first place. She'd been up all night drinking and smoking and partying, and she'd actually been having sex with a partner, and shortly after became symptomatic quickly. She had a history of medications, perindopril, statins and beta blockers that she'd been not compliant with and didn't take very good care of herself at all. Main concerns in a primary survey was her respiratory status was quite troubling. She had a respirator 40, speaking in word blocks, 79% SATs on room air, bilateral basal and midfield crackles and wheezes. And the P1 crew actually noticed some hemoptysis in a tissue that she'd coughed up. Her BP was quite high at 180 on 112, monitoring at a sinus TAC with no chest pain and frequent multifocal PVCs, and on their ECG a long QTC of 488 milliseconds. And other than being cool, diaphoretic and mottled, her OBS were actually okay, but her GCS obviously later declined, and that's why they became concerned. So initial treatment, the first treating officer auscultated the patient's chest, noted fairly strong expiratory wheezes. So they went down the pathway of treating per the asthma protocol. She had very difficult IV access, and that was sort of the initial management in the car. On a reassessment, once they finally got ready to go, they switched her over to a non-rebreather mask as the other P1 officer on scene noted fairly loud crackles. They commenced aspirin and GTN. By the time they got to us, the patient had 1,200 mics of GTN and 300 of aspirin. Their ECG wasn't great trace. It was quite difficult to get due to the patient's agitation and diaphoresis, and that further deterioration was the reason they called us. So I feel for that crew because there was a lot going on in that initial scene. So what happened? When we met them on the roadside, we immediately commenced CPAP at 5 centimetres of water. The patient was quite compliant. We completed the GTN regime and gave 40 of furosemide due to the patient not being compliant with any oral diuretics that we knew of. To complicate things, the patient was having frequent runs of non-sustained VT. Per protocol, we drew up some amiodarone, but it wasn't administered. Had the patient gone into VT, that might have changed. We applied the defib pads in case the patient deteriorated further, and there was some concerns noted by the P1 crew that maybe their initial dose of salbutamol might have contributed to those runs of arrhythmia. We'll discuss more on that later. And there was also a discussion at that point about administration of morphine for the dyspnea and anxiety the patient was experiencing. But obviously, as this isn't supported by our pharmacologies, it was withheld. We expedited R1 to Shoalhaven Hospital and passed a code 3. And there's an example there on the right of the ECG and runs of non-sustained ventricular tachycardia. On arrival at hospital, patient was placed on CPAP and a GTN infusion. She also was given an amiodarone infusion of 300 milligrams for the first hour, which was later then bumped to 450 over 12. Her imaging on POCUS showed a severely dilated left ventricle with apical hypokinesia, so not moving well at all. And the transthoracic echo showed a dilated left atrium with mitral regurg, pulmonary hypertension. VBGs, ABGs showed a troponin T that had increased, so that was positive. The NTP-BNP, which is a brain natriuretic peptide, it read at 7,476, and by standard, anything over 900 in a patient of this age is a fairly definitive indicator of APO. She had some respiratory acidosis, was obviously hypercapnic by the time they took bloods, and hypoxic as well. I've got some examples of ECGs that this patient experienced with some milder anteroseptal STE there, and later a fairly slowing rate with a long QT and marked biphasic precordial ST elevation. Takotsubo's, we don't know, I didn't know much about it. Broken heart syndrome, it's called. It's noted that way due to similarities between the shape of the LV during the onset of effects and an octopus trap. So quite a narrowing mid-ventricular region, and then quite a dilated apical part of the LV. Patients might not have pain or APO. They could just be presenting with SOB. So it's important to get a good history and note the demographic. The cardiac angio can also be negative for an acute conclusion. So that's a fairly good indicator that the patient is experiencing Takotsubo's. This is the decreased left ventricular ejection fraction is typical of dilational cardiomyopathy. So you're getting all of those lovely effects of that there. What's happening to our patient? Takotsubo's plus minus flash pulmonary edema in this case. In these patients, the neurohormonal overload causes a sympathetic overactivation during basically an overreaction to a stress response. You get a surge of circulating catecholamines, increased afterload, fluid shift into the lungs, and then on top of that, catecholamine-induced vascular microspasm increases ventricular wall stress. You get this classical apical ballooning of the LV due to an increased amount of sympathetic nerve fibers in that area, and a decreased left ventricular ejection fraction percentage and force of contraction, leading to basically overall a massively crashing cardiac output. So what are the implications I learned on this job for my ICP practice? As I said before, I spoke with the P1 crew about the administration of salbutamol to a pulmonary edema patient. Historically, we've always been told that salbutamol to an APO is a no-no, but it's not technically contraindicated per protocol. Hypothetically, that beta-1 activation may lead to tachyarrhythmias and increased sympathetic tone. But I spoke to a few staff specialists locally and at Liverpool who concur that giving a small amount of salbutamol, in this case 5 milligrams, might have actually done the patient some good. And there's a study in 2014 that stated that high-dose salbutamol during this period doesn't improve oxygenation or lung utilization, but can cause tachycardia. But that's sort of up in the 10-15 milligram range. Furosemide dosing, we had a conversation about that between myself and my mentor. There'd been a comment made earlier in the week about the ICU having to juggle patients' blood pressures and diuresis, and what the optimal dosage was. In other states, only normotensive patients, particularly in Ambulance Victoria, receive furosemide, and there is also the option to match the patient's daily dose. The literature is conflicting in this based on my research. Some articles show that higher doses, i.e. greater than 80 milligrams, are associated with poor outcomes. However, low doses less than 40 milligrams exert less respiratory effect, kind of defeating the purpose. The dose trial in 2011 stated that a high dose strategy was associated with greater diuresis and more favourable outcomes in some secondary measures, but also with later worsening of renal function. However, obviously this has got to be weighed against the patient's initial presentation as to the dosing they receive. As far as morphine goes and managing dyspnea anxiety, it was an interesting point and gave me a bit of thinking to do, and I did a bit of reading. The 2010 RACGP guidelines include 1 to 2 milligrams IV morph in management of APO. I'm not sure whether that's actually changed or not. I couldn't find further information on that. But a 2019 Canaries University review concluded that the hemodynamic and sedative benefit of morphine may be opposed by an increase in mortality, ICU admission, and adverse offence. So until there's actually a formal RCT done, the use of morphine for ACPO should be limited, and that's probably why it's not in our protocols as well. Literature, however, doesn't take into consideration low dose amounts, such as what we use in our S9 protocol, so 2.5 to 5 milligrams subcut, and it did actually include doses used in intubation. And lastly, giving amiodarone for an episode of non-sustained VT. In this patient, administrating on the back of long QTC may potentiate torsades, but there was actually a statement made by the cardiology team that it'd be fine to give a dose of 250 or 300 as a bolus, which kind of confused me, and I stayed well away from it, even though they were aware the patient had a long QT present on our serial ECGs. Lignocaine might be more appropriate in this scenario, but obviously it's not indicated per protocol 212. So takeaway points for me, Takotsubo's is pretty rare, but clinicians should be suspicious of sudden onset of shortness of breath in postmenopausal women, so especially people 45 to 55 with mental and physical stresses. And in the case of acute pulmonary edema, obviously doing a very good case history and a good respiratory assessment to go down the right treatment path as soon as possible. The wheezes can occur in APO, but large amounts of NEBs in these patients may actually exacerbate their condition. CPAP and GTN are, of course, our standard for a reason. There may be one day a role for morphine in treating dyspnea and anxiety associated with APO, but until further trials or an RCT are completed, we're going to stick with our basics. That's pretty much it, guys. I hope you've enjoyed this presentation, and there's all my references. Thanks for watching.